If I have a patient who is an avid cold plunger, I know without question that they are going to handle their postoperative recovery phase leaps and bounds better than somebody who is not accustomed to that. And I think that that gets really into the anxiety and psychological part of it, of purposefully putting yourself in an uncomfortable position, knowing that there's a long-term benefit to it.
Our next guest, Dr. Chesnut, is a board-certified plastic surgeon. The Anti-Aging Medicine World Congress in Monaco said that Dr. Chesnut is probably the best example of the new generation of modernly trained international surgeons. In that same long quote, they threw out words like intelligent, innovative. Dr. Chesnut has so many letters after his name: MD, FAAD, FACMS, FASDS. He is an assistant professor at the University of Washington School of Medicine and the founder of Clinic 5C, a clinic that can help improve your exterior appearance, including plastic surgery, but really focused on reducing biological age, helping people to look how they feel and to feel even better.
I do not use general anesthesia for my procedures, and I think it's important to delineate that I'm working in a facial plastic realm. So kind of from the collarbones up, right? So I'm using...
Hi, my name is Chris Burris. I'm a longevity expert and the chief scientist at a lab focused on a longevity molecule. My primary focus is to help people live longer and better lives with science. Make sure to subscribe and share so you and your friends can live longer and better. Well, actually, so you and your friends can live beyond the norms.
Hi, and welcome to the next Live Beyond the Norms Health and Longevity podcast episode. If you're a regular follower of my show, you know that I love to speak with board-certified physicians. And when we know those board-certified physicians are open or even leaders to what biohackers and the longevity crowd are pursuing, it just makes it so much better. Our next guest, Dr. Chesnut, is a board-certified plastic surgeon. The Anti-Aging Medicine World Congress in Monaco said that Dr. Chesnut is probably the best example of the new generation of modernly trained international surgeons. In that same long quote, they threw out words like intelligent, innovative, progressive new techniques, and uncanny aptitude. When you couple this with the American Medical Association's description of the most valuable characteristics for an excellent plastic and reconstructive surgeon, those words are integrity, compassion, commitment to excellence, humility, creativity, ingenuity, scientific curiosity, dedication, and, interestingly, humor. You have the makings of an interview you do not want to miss. Dr. Chesnut has so many letters after his name: MD, FAAD, FACMS, FASDS, MDS. We're not going to get to even talk about all of those. He is an assistant professor at the University of Washington School of Medicine and the founder of Clinic 5C, a clinic that can help improve your exterior appearance, including plastic surgery, but really focused on reducing biological age, helping people to look how they feel and to feel even better. Dr. Chesnut, thank you for joining us today.
Oh, thank you for having me on. Really appreciate it, Chris.
Excellent. So the path to MD is already hard enough, right? A lot of people are like, yeah, well, you're going through your maybe middle school years and your high school years, like, I want to be a doctor. And then you start looking at the path, and a lot of people like just drop out before they even start college. So that's a long path. And then you add another 8+ years, including surgery and plastic surgery. Can you talk a little bit about growing up and what probably pushed you towards medicine in the first place? And then did you always know you were kind of destined to be a plastic surgeon, or was there something on your path that put you in that direction?
Yeah, I don't have anybody in my family that was in medicine. So for me, there's a picture of me with a stethoscope when I was a little kid kind of thing. And I look back and I'm like, oh, must have been thinking about it then. But in full honesty, my mom was a nutritionist, and that was my undergraduate major. And so that was really the direction that I was sort of interested in at a young age. And I pursued that through undergraduate. And I kind of always kept medicine in the back of my head as an option, but didn't really have any examples or know that much about it. And I started exploring it in college. And as the story goes, you start getting into the pipeline that you talked about, that is test after test, study after study, metric after metric, and start pursuing and getting into it. And in that process, interestingly, I would say, lost myself a little bit into what I was really excited about when I was younger, which was sports and artistic sort of, if you will, like right brain types of activities. And I got very into the scientific, needs that I had to get through medicine and medical school. And so as I was getting into choosing specialties, and as you know, there's just such a broad array of things that you can do, from never speaking to a live human being to never touching anybody to just doing stuff all the time. I really found myself in the doer category and the sort of more surgical, interventional, procedural types of things. And I really found that 3D spatial part of my brain again that I really had loved when I was younger, that artistic side. And there's a bunch of outlets within that. I would argue that even orthopedics is very 3D and spatial, but I really liked the more creative side of things. And so that led me down the roads of these reconstructive plastic types of surgery paths. And there's really four things within that we call the core four cosmetic specialties. And that's dermatology, facial plastic surgery, oculoplastic surgery, and general plastic surgery. And so I found my route through that, going through dermatology and then facial plastic surgery into sort of where I am now.
Man, that's pretty cool. So your mother was a nutritionist. I think from what you briefly said there and some of what I read, you were in sports. Were you trying kind of early on to optimize nutrition for your sports and probably the only one of your kind of compadres who are pursuing athletics who are thinking that way?
Yeah, I mean, that was a long time ago for me. And, in hindsight, my mom was very progressive. I didn't know it. I thought she was a little kooky in the things that we were doing. Because I was thinking about nutrition as a grade schooler or middle schooler, pre and post exercise. She was having me, in hindsight, take advantage of my glycogen synthase activity after exercise by, supplementing protein and carbohydrates in certain times. And, she wasn't hardcore doing that, but she was just guiding me down this path, which ultimately, as I got further into my athletic career, was probably the foundation of a lot of my like peak performance types of mindsets that I have. So kind of fun in hindsight to look back at that. And, it is, when you start to see your parents in that different light as, oh, they knew something that I didn't know back then. I certainly had that from a nutritional standpoint. And, always say you come back to the religions of your youth, right? Well, for me, that was definitely coming back into nutrition a little bit as I explored my own paths along the way to get where I am now.
So you're on this path, right? You got a little lost in the science and then kind of got refocused on the creativity. So ended up in plastic surgery. And now you're incorporating cutting edge processes. Like, I think somebody, if you were the only plastic surgeon they ever met, they were like, this is how all plastic surgeons do it. I
Right.
don't think that's the case, right? What kind of drove you, as you're starting plastic surgery, how quickly do you start incorporating things that, most other plastic surgeons aren't doing? And like, what's the kind of story behind that?
Well, I've always carried this mindset of an athlete for myself into all aspects of my life and career. Meaning, when I was through medical school, when I'm through residency, and you're going through all those challenging times, I am treating myself in that preparation, in that execution, and in that recovery phase as though I was an athlete. And that was just my background. That was the lens I knew on how to do things. And as I got into practicing medicine, I mean, that's even how I learned in a lot of ways, was doing it that way. And then as I got into practicing medicine, I was applying those same principles to my patients too, thinking, okay, we can get them ready for surgery. We can optimize what's happening during surgery. Then, of course, the recovery, which in my opinion is the most neglected part of the whole process. And I think that we're really going to get into how we can optimize recovery from any surgery. It does not have to be a cosmetic facial plastic surgery type of situation, but that's really where I saw the gap. And so I found myself looking at the science and finding a lot of overlap with the athletic community or with the biohacking community, all sort of meeting up in this space that's really just optimizing our body's ability to heal and recover. And that sounds a little cliche, but it's quite true when you start seeing the intersection of all these different types of things. So it came as a natural fit to me. It's definitely part of just a progressive and innovative mindset, as you mentioned. And, as you get more capacity within your practice, these things start to develop. And if you see value in them personally, if you see value in your patients, and I'm very fortunate to have patients who are high achieving peak performer types of people anyway. And so they're seeing the value here too. And that just fuels my obsession with it a little bit as well.
Was there any one technology or kind of biohack that you kind of first laid into the groundwork, and then you're like, wow, that's really effective? And kind of really drove additional ones.
Yeah, absolutely. I mean, I have a personal answer to that question of like the first thing for me, but when it came to patients, it was definitely hyperbaric oxygen. And I
Mm.
think that is sort of the quintessential example as we get into talking about these recovery modalities where there's an overlap with everything. And the cool thing about hyperbarics is its real foundation is more in medicine than it is in athletics or biohacking. And as we go through the cycle, you'll find foundations in different places often, but hyperbarics has FDA approvals for different things from decompression illness, the bends basically for divers, all the way through wound healing applications. And we know without question that hyperbarics improves post-surgical recovery or wound recovery, that whole wound healing curve that we're on, it makes it better, right? Well, you take that and you apply it to a post-operative patient, really great results. Anecdotally, you cannot argue with what you're seeing in your patients. So that just clicks, right? But we also see that happening with the biohacking community coming into hyperbarics. And we see it with athletes sleeping in hyperbaric chambers. It's become quite in fad. Well, it's no accident. They all play together, they all work together. And this one has a really strong medical foundation that's then carried and spilled over into other things.
Regarding hyperbaric, right? There's we'll call it kind of the layperson's chamber is kind of a soft-sided one. I think it can get to like 1.5 atmospheres, and then you start getting into actual metal tanks. What are you talking about typically?
Yeah, so I use hard-sided or metal tanks for my patients, and you can find those, zippered, soft-sided 1.3 to 1.5 atmospheres usually. But when we get into the hard-sided tanks, we can just get to higher pressures. And so for a post-surgical application versus a wellness application, that's going to be a little bit better and more optimized as to what we're after there. And there's certain ranges of pressures, we call them dives. There's certain ranges of pressures that I like to have my patients in postoperatively, and those can't be achieved at the soft-sided chambers. There's a very basic equation to how hyperbarics works, though, that is just simply the oxygen concentration, the pressure of the chamber, and the time. And so you can take these soft-sided chambers and manipulate them to have benefits that are similar to a hard-sided chamber. It just physically takes a lot longer. And in a post-operative situation, I don't want my patients in a chamber for hours and hours on end. We kind of like to get to the upper limit and extend it there.
Yeah, that makes a lot of sense. Are you at 2 atmospheres? I don't even really have a good. Is it 2 atmospheres? Even higher?
Yep, 2 atmospheres, which is 100 kilopascals, is sort of the like key sweet spot pressure that we like to get people to for their post-operative dives. That's kind of the wonderful benefit. It's interesting because hyperbarics does have a pressure portion in addition to the oxygen delivery. So I love to, if I take a water bottle in there, a plastic water bottle, it will crush under the pressure of the hyperbarics. And so that's a really great illustration for my patients to say, you have some swelling in your face post-procedure, we're going to have a diffuse pressure on that swelling that's going to physically help drain the swelling and get the extra oxygen delivery, which has the whole physiologic benefit. So it's a really nice double benefit to the sort of expediting the recovery after surgery.
At risk of derailing things, I find this fascinating. So you go through residency. It's called residency for a reason. It's basically extreme sleep deprivation, right?
Right.
And all the data says this is a bad plan. Like, do you see that evolving? Like, in hindsight? I know when you've gone through it, it's very hard to go like, well, no one else should go through that, even though the science says no one else should go through that. There's no value. Wait, do you have the logic side and feelings, or just the logic side?
I mean, I would say I've tried to get to the logic side of it now. And it's a similar, like you can talk about the equations everywhere. There's an equation of time, right? Just how much time it takes to get good at things. But I think that's really a quantitative and ignoring the qualitative aspect of it as well, right? Because where I am now, if I were to give advice to residents, I would be telling them, you need to be optimizing your sleep. You can't learn adequately if you're not having optimized sleep. It's just straight up how it is. And so the system is broken in that way, and it's a little dated, and I believe there's a strong misunderstanding. And I actually see this extending beyond residency into the mindset that a lot of my colleagues carry. And, as a little story, when I was a medical student considering specialties, orthopedics was one of those things that I gravitated towards. I was a jock, if you will, that quintessential setup. And on an orthopedics rotation, one morning at 5 a.m. rounds, after we'd been up all night, seeing people till 3:30 in the morning, start rounding, the way that the order of the residents, I was a medical student, the way that they sat across me just happened to go like first through fifth year residents. And it was just left to right how we'd read. And I found myself looking down the line as time went on, and I can identify with that first year resident. He's kind of like me. And then the second year resident, I saw like a little bit more misery and a little bit more metabolic syndrome. And it went all the way through the fifth year resident, who was relatively obese from a BMI standpoint and miserable. And I thought, I can't go through that. That cannot be the path that I follow. Something has to be better. And the sad part is that I see that now. This is like one of my missions in life as a surgeon, is to optimize the performance of my colleagues and surgeons as well. The things that your audience is very familiar with is not the norm. So speaking of living beyond the norms, let's talk about practicing beyond the norms. This is not how surgeons think. They are shells of their former high-performing selves all the time, and they could still be that, but it's beat out of them, often in residency, like you're talking about, or into real life where they're overworked, they're burning out. These are really high-performing, brilliant, capable people who are not getting enough sleep. They are not taking physically care of themselves. They are not achieving peak performance. They're not going into every surgery like it's the biggest, most important event of their life. It's like this case number today, and I have 3 other ones after it. It's really hard to get to peak performance over and over and over. It's like asking a baseball pitcher to pitch every night, 9 innings. They're not going to be at their best. And so one of my missions is to sort of change that and help with what you can do within reason as a surgeon to optimize the performance, which is great for every patient. Every patient going into surgery, it's a massive event for them. And I believe that we should be viewing it the same way, from, we talk about the emotional side of things to all the way through the physical and the performance side of things. We have to take those into account. And I think that even within the parameters that currently exist, there's better ways to do it. And sometimes it's simply, what are you eating? How are you sleeping? What's your cognitive and physical load leading into your caseload that week? How can you pull those simple levers and make things better for what's existing? And again, you're touching on a big mission of mine within not just my field, but I'm just going to say medicine in general.
Yeah, and I know that you had sent, like, you have and we might not get to this, but you have quite an extensive preparation for each surgery, which is exactly, I think, what everybody thinks is happening for every surgery. And I think what I'm hearing is, and it actually makes a lot of sense, that's not typically what's happening, right, for going into every surgery. All right, so you've got these protocols. Talk about what positive impact these protocols have, including on plastic surgery, but also how it relates to kind of longevity, since we're a longevity podcast.
Yeah, so everything that I'm talking about is not necessarily specific to my type of surgery or my type of practice. So I'll just say that up front. If we're talking about having your meniscus repaired post-operatively, if you're an active, weekend warrior dad or mom, all of these same things apply. But applying what I'm seeing in my patients, I like to have them coming in. So I take that same framework of an athlete: preparation, execution, recovery, for my patients as well. So I have a preoperative protocol that's not that complicated, but I want my patients coming in optimized on their diet, their inflammatory profiles, their antioxidant profiles. So there'll be some peptides and things will start before. I want them, even, and this is controversial, but I want them limiting their seed oil exposure, what types of cleaners they're using, so they're not in an inflammatory state coming in. I want them ready to roll. Then the surgical part, that's sort of up to me. And I use a lot of regenerative medicine during their procedures, regenerative medicine being autologous stem cells from their fat, or platelet-rich fibrin little matrices that I'll use that are growth factors from them. I use intraoperatively. Then we get to the post-operative part, and that's where things are really, really different. And I've talked about some of those things. I've talked about hyperbarics, which has a strong root in medicine. Something like pulsed electromagnetic fields, that has a sort of when we talk about all those avenues coming in, there is a strong medical foundation in that as well. It's FDA approved for healing bones, and it does so by creating extracellular matrix. But there's evidence in our plastic surgery literature that it helps heal wounds that are having trouble healing. So it has this kind of full circle application to it as well. IV nutrition, and that IV nutrition is generally customized to the patients if we have that genetic information from them. But even if it's not, we know the building blocks and things that are needed to fill in those gaps to create new collagen, create new elastin, what minerals and micronutrients are important in that, what we can do to help maximize their anti-inflammatory profile, whether that's adding glutathione, how we can optimize their mitochondrial function with NAD. All of that's happening from an IV standpoint afterwards as well. And then getting into what this does for the overall longevity. When my patients come into surgery, they often know about a lot of these modalities. They've heard of them. They've maybe applied them a little bit. They know what they can do. But when we get through this whole process, they're generally leaving with a whole different level of knowledge, a different experience, having seen what it can do for them firsthand in a very acute setting. I mean, what I'm really doing here is causing a response of healing. I'm just doing it on purpose and then trying to optimize the response to it. Well, that's happening every day in our daily lives. Whether you have a glass of wine the night before, you've got some healing to do after that, whatever it may be. If you had a stressful workout, we've got to heal from those. So my patients generally just leave with a different understanding of what these can really accomplish in a very, acute microscopic setting. And they say, oh, these are helpful. And so I find that there's a lot of little directional changes in life after this, which, it's a beautiful side benefit for me and my patients.
Yeah, go see your plastic surgeon and become healthier the rest of your life.
I
That is
mean,
not. That
yeah,
is
it's
not.
crazy. It's crazy to say, but it's quite true. It's, all kinds
That's
of
phenomenal.
metabolic changes. Yeah, I love it. I love it.
Right. I think it's kind of like if, and I've had interviewed a lot of. I'm relatively new to kind of this space, this health space. I had a lot of amazing conversations, through this podcast, and it really does feel like each person that I get to interview has that same impact. And yours is interesting. It's medical related, but in no way is anyone thinking I'm going to go to my plastic surgeon because I want these changes, and then I'm going to be healthier. They know they're going to feel better right inside, but to come out of that, and with all these people that I've interviewed having a slight change in trajectory, right, like healthier. I think that's absolutely fantastic.
Yeah, and it's interesting, Chris, that I think a lot of times it's a chicken or the egg phenomenon with my patients too. Sometimes they're sort of already on this longevity and wellness journey. And as they're rolling down that road, they start to feel fantastic inside. And it's an interesting thing because that's very subjective, what you're feeling like. You could argue there's some objectivity to that. And we can see that when we look at metabolic panels and all these types of things. But then they start looking in the mirror and they're getting a mismatch, and it creates this cognitive dissonance with them. And so very often I hear from my patients, they've been on this health journey and I just want to look how I feel, right? And this is where, as we really get down the road, that's quite true. Because when you talk about extending lifespans and we talk about improving health spans, the way that you look is part of that, whether we like it or not. And so I'm often just part of that journey. And I kind of love being part of that journey. So one of my favorite things that somebody can say to me is, I just want to look how I feel. Well, let's do that. Because if you feel good and look good, that's just a magical combination rolling down the road.
And in my introduction, Meg, I pulled that from your website. Like, you're helping people to look how they feel, and then I think, and I added, feel even better. I think that's awesome. You mentioned IV nutrition and then genetic testing. It sounded like maybe not everybody gets genetic testing, so you might not have the right data. What do you get from genetic testing that kind of drives what IV nutrition you might be kind of interested in getting into your patients?
Yeah, so if when available, and I try to encourage my patients to do this, not everybody wants to, and it's totally fine. But if they don't have it already, or if it's open and they're available, we'll generally do a genetic profiling of them. We'll do nutrigenomics. We want to know what their foundation is coming in, and some of those like main things. I mean, there's a million examples, but if we just get into some of the more common basics that we'll find, you find an MTHFR mutation, that they don't methylate their B vitamins as well, specifically folate in that case. So great, we can, make sure that we're using methylated folates. And then again, from a lifestyle or from a life-changing road for them moving forward, that's a big piece of information for them to have. We'll find changes in fatty acid metabolism. We'll find changes and like an interesting one is like an aldosteronase deficiency, where we'll find this rare person who has an aldosteronase deficiency, and for them, sodium will actually kind of raise their blood pressure moving forward. And so we'll know that they actually need to be sodium aware, and that helps us even just with our intraoperative blood pressures and how we're using our fluids. And so there's lots of little bits of information to that, but we have a basic idea with our IV nutrition, even if we don't have that, as to what we're going to do, but we'll customize amino acids, fatty acids, and then of course some of the vitamin profiles to go with that.
Yeah, that makes sense. I did an interview and then actually followed up because I did a genetic test for kind of what I won't say food preferences, like what my body does well with, whether it's carbs, whether it's proteins or whatever, and learned some fascinating stuff about that. And one of the things I really liked is Dr. Sam Shea, is his point that a genetic test is probably the most cost-effective test you can take, because although it may be expensive up front, the genes don't change, right? The rest, you got to test other things, and you may need to be testing, every 6 months, maybe even more frequently. But that genetic test gives you that kind of baseline that is good forever. It's kind of cool.
Right, absolutely. And it although the upfront cost is there, the longevity benefits, and even honestly for a lot of people, just what you're going to save in supplements by, being able to, usually for people, it's not adding, it's taking away from things that they're already utilizing, or really honing down to be more specific. That's the best way to do it, without a question, is sort of having that genetic profile moving forward.
Amitai introduced us. He's amazing. He's got amazing podcast. He's, in the biohacking space, kind of focused on skin. You've had other interviews with other in the bio. Was there a point, did you kind of always know that this was in the cutting edge stuff you were doing was in the biohacking space, or was there a day where you it all came together and like, oh, this is what we're doing that, and we're biohackers?
Yeah, I mean, this is where I love the kind of idea of cross-pollination, which I am very much in my background and training, coming from derm into plastics and having all kinds of different cross-pollinations, or this idea of an alloy, kind of taking the best of these different worlds and, kind of maximizing the end product by mixing them together. So there's a little bit of that, but, as I said before, there's just a lot of overlap in this anyway. And the word biohacking I kind of chuckle with that a little bit, because a lot of this is like, well, I don't know that we're hacking anything. We're just kind of taking advantage of those things that are already there at our fingertips, by using things that we've known in medicine for a long time are quite helpful. And they're sort of getting discovered by a group now who maybe didn't need what the original medical indication was for, and they're calling them biohacks. And I'm like, well, we've been using this for a long time. This isn't necessarily a hack as we get into it. But, it is fascinating where it goes in the future, because we know just in the acute setting and the post-surgical setting and what the benefit can be. Then it just takes that little innovative progressive thinking to say, well, okay, what can this do for just real life stressors, for hormetic doses, to make all of those more applicable and better, and to improve our longevity moving forward. That's really it's a natural progression of innovative thinkers, honestly. And I love kind of being in that group and chatting with people like you who have those ideas. And it's interesting that it's so grasped, and I understand why it's so grasped by that world, because it's like, well, it's giving legitimacy to things that, have been labeled as this biohack. That's kind of like, well, you're just trying to get around the system. Like, no, we're not getting around anything. This is built in. Yep.
We're actually trying to use this system called science
Right.
and the available data that's out there.
Right.
But there's also a lot of data that can be misconstrued, misapplied, misappropriated, maybe a good word also.
Absolutely.
All right, let's get a little focused. So you're advocating for a reexamination, if not an outright stop to fillers. I think some of this is for health reasons, but you also talk about kind of perception drift. What is your position on fillers, and talk a little bit about perception drift?
So fillers, just to kind of fill in the gap of what that is, I'm just going to define
Unintended.
fillers as, yeah, exactly, right? Fill in the gap. Hyaluronic acid is the main type of filler that we're talking about here. These are a gel of cross-linked hyaluronic acid. Hyaluronic acid is part of our skin, or part of our soft tissue of our face, I should say better. It's an extracellular matrix, glycosaminoglycan. It's meant to attract water. So it exists outside of our cells to attract water. Well, we can take that hyaluronic acid, cross-link it together, and make these gels. And the gels can have different hardnesses and properties, if you will, and they get injected into the face to add volume back to the face. These go back about 30 years, really popular over the last 10 to 15 years. And there's other types of fillers as well besides these hyaluronic acids, but those are the predominant ones. There's biostimulators that people inject in the face to create more collagen, which is basically a foreign body reaction that causes a fibrotic or scarring response that creates volume. But the idea with these has been, well, you put them in the face, they add volume, and they go away after 6 months or 12 months, or some of them last 2 years. Well, when you go back now decades, we see that that is not true. That's based off these FDA trials that were just looking at how long it corrected a nasolabial fold. Oh, it corrects it for 12 months, and then the correction kind of goes away. And so the assumption was, well, that the filler is gone. Well, that's not what's happening. The filler's still present and has just moved out of that area, changed its composition, and the filler is quite present in the soft tissue still. And as it breaks down over time, it starts to attract water and do what hyaluronic acid does. So there's this big misunderstanding that you get filler, the correction goes away, you get more filler, the correction goes away, you kind of keep on this cycle, but in the end, you end up collecting all of this hyaluronic acid in your skin that has changed the quality of our soft tissue. It's quite literally absorbing water, and you have a face made out of gel instead of a face made out of fat, skin, muscle, and bone. So that thought paradigm around how long it lasts, how frequently you need to treat, and how it goes away has been shifting very slowly. And I've been pushing that shift a lot because as a surgeon, I see this in soft tissue decades and decades and decades later, around the eyes, around the lips, whatever it may be. Person may have had it, in the 1990s or early 2000s or whatever it is, and it's still there now. So it's not going away from an in situ, like in position tissue standpoint. We know from imaging studies with MRIs, we know from biopsy studies inside of muscle of the soft tissue of our face that this is still present years and years later, but it's still being treated with this idea that, oh, it just goes away. We just get more and more. And part of that's a financial gain because it's a business model of, repeat, but a lot of it's just misunderstanding, right? So I love this idea of Hanlon's razor that, do not attribute something to malice that's better just attributed to stupidity or just not knowing. So I think a lot of people just don't know. And I'm not saying that's stupidity, but in Hanlon's razor, that's the idea. People just don't know. They're not knowing how to apply it. And so they're just repeating the filling. And this is what we're seeing with just the distortion of faces in the long term. We see this all over Hollywood. And interestingly, when most people come to me now in a surgical situation and they say, I don't want to look like so-and-so in Hollywood, very rarely now is it a surgical situation. It's shifted. It's filler that's causing the look that people don't want because it's so much more common. So it's this little thought paradigm there that you think that's surgery, but it's not surgery. It's filler. And that's because it's getting topped off over time. And so this idea of a perception drift versus having some dramatic change is that the filler does its job bit by bit by bit over time. And so over a matter of years, you start to look very unnatural, but it happens in such slow increments that your perception in the mirror adjusts to your new norm as time goes on, right? So you get a little filler, you look in the mirror for 6 months, and that's your new norm. And then you get a little filler and you adjust. And by the time you get a few years down the road, you look back to where you started and you're unrecognizable. You look quite unnatural, but it didn't happen dramatically in one instance. So you kind of have lost that. The same thing happens with the people putting the filler in, the injectors, but they're getting a double feedback because they're getting that same perception drift for themselves in the mirror every day. Plus, they're getting the perception drift for all of their patients that come in the door. So they have this double feedback loop happening for them where, they see Sally that they've been seeing and she looks different, but the last time they saw her, she just looks a little different than that. And they get this incremental change for themselves. And so it's a little bit of a vicious cycle that happens. And eventually we like to try to look at original photos pre-treatment and where somebody's at now. And then that kind of helps them snap into realizing like, oh my gosh, I look quite unnatural and I don't look like myself anymore. And again, this is not a surgical change. This is how these fillers are going. And then we get into how we manage the fillers afterwards. And that's a whole nother conversation, that the idea is that you can put this enzyme on and they all just magically evaporate out of the face, which gives this sort of safety net for injectors too. Well, if you don't like it, we can just dissolve it. And so it makes a little bit more of a cavalier use of it. But the issue is the dissolver doesn't work that well either. So now you do want to get rid of it. You finally realized this isn't good. You look unnatural, and it's very difficult to just erase and get rid of, which is the thought paradigm of, fixing it if we don't like it.
And I think I saw a note, or you sent me a note, dude, like a lot of times when you're going in to do some plastic surgery, you're actually kind of having to deal with and try and manage these fillers. So if I understand correctly, like maybe you put fillers, correct me on any of this, right? For crow's feet or wherever you're putting fillers. And then over the next 6-12 months, maybe 2 years, they just start diffusing into localized areas of the skin. And the initial thought was like, well, look, they're gone. And the answer is no, they're not gone. They've diffused and you don't really see them anymore. That's just seems really kind of scary. How hard is it to manage these as you're going in kind of after the fact?
Yeah, there's a little bit of time dependency on that. The factors that we determine how do we get rid of filler are what type of filler is it, sort of how hard is it, or what the properties physically are, how long it's been there, and where it's located, right? So certain areas are easier to access to remove, but it's this idea of that, like I said, the enzyme doesn't work that well. And so when filler's really problematic, sometimes we're going in to surgically remove it. Surgically removing filler is much easier and much more desirable when we can, let's say, access it from a scarless location. So if there's a bunch of filler in the lower lids and cheek area, I can go through the conjunctiva, the inside of the eye, access and remove that filler with no visible access, no visible incision. So that's a relatively low penalty way to go remove it. But was that filler placed last week? Because that makes it really easy for me to go get it because it's located in one place, hasn't diffused. It's one ball of filler sitting under there. Easy, no problem. If that filler is 25 years old, we know that it has migrated throughout the muscle, throughout the fat pads, throughout all the soft tissue planes. So that one ball is now widely distributed. That's a much more difficult situation to manage from a manual removal standpoint. And then I also have to take into consideration the trauma to the soft tissue so let's say your eye muscle, we have a little muscle around our eye that closes it. If that is full of filler, it's a very thin and wispy muscle. I have to really weigh how much trauma or damage that muscle can take in the process of removing the filler to get rid of enough filler, but also not cause any long-term issues. So it gets problematic and challenging. And this is one of the main things that I do because it is a really difficult situation to manage. And like you said, Chris, it's rare that I see somebody who's interested in cosmetic procedures who hasn't at least tried filler because it's promised as this panacea of it's simple, it's a low, barrier to entry, it's relatively inexpensive. You can get it on the corner next door. There's 5 places within a mile of you that will do this for you. So it's natural that you can, go try it and it makes sense. It's so simple sounding, but then it just comes with a lot of misunderstanding and creates some complicated situations down the road.
Wow. Well, yeah. Good luck on fighting that fight, right? Like
Right.
that sounds like a fight worth spending time on. Um,
Absolutely.
so when I was getting some more background information, you talked about inflammation. You brought up a point that I've always questioned. If inflammation is part of the healing process, is it really a good idea to stop or reduce it? Can you talk about your approach to inflammation, how your approach may differ from other physicians, and maybe how you can throw stem cells may fit in that mix?
Yeah, this is a good question, and I'm not going to say strong feelings about this, but I have differing feelings from a lot of my colleagues, as you're hinting to. Because if we look at the science of how we heal, or let's say wound healing, but just how we heal, the first part of that is the inflammatory phase of this healing process. It's very important. And a lot of changes happen within there. A lot of cells are moving around, a lot of growth factors. There's a lot of cellular signaling that's happening. And the first few days of that are wildly important to what happens. The downside is that comes with a lot of swelling and things like that that go with this inflammation. But this is a good inflammation. This is how we heal a wound, whatever it is, any injury. And so the norm within this is to, in the postoperative period, is to give somebody a oral or sometimes IV steroid. And the steroid is an anti-inflammatory. These are generally corticosteroids, we call them, but they just stop the inflammatory response. And if you're in an inflammatory response, like you're having anaphylaxis to something, well, those steroids can be really good to shut down that inflammatory response and save your life. But in this situation, we want that inflammatory response. It is healing, and shutting it down, especially in the initial phases, makes things more comfortable, but it is not good for the long-term healing of the wound. It's more comfortable for the patient and it's more comfortable for the surgeon because there's not as many questions, there's not as many, there's just not as much sort of for the patient to go through in that initial postoperative phase. So it's this, I think it's one of the comfort crisis or the paradigm that we have in life. Like comfort is a slow death. We need to prefer pain a little bit sometimes. And this is quite literally that situation where, chasing that comfort in a sense inhibits our long-term result and inhibits our healing. So I do not give postoperative steroids. I vehemently avoid them, actually. And this is very much different and very much not the norm with how surgeons function. I do like to take advantage of the inflammatory phase of healing, take advantage of the inflammation that's happening by trying to optimize it. And I'm going to say optimize it by using something like stem cells or autologous growth factors during and after the procedure, because those are really great at orchestrating the migration and change of that inflammatory phase, of the cellular shifts, of the cellular signaling that's happening. We can make that happen better, if you will, by utilizing these other options instead of shutting it down altogether. So it's a very different way to go about it, and it does involve a little bit more maybe initial swelling, but better short-term healing and way better long-term results.
Mm.
So it's outside of the box a little bit, but it makes sense when you think about it from a scientific standpoint.
I've just always thought like we're dampening our response, like our body was designed to do this, and in my mind, and maybe it's just because of the prevalence of this opinion, maybe there's some situations where like our bodies over the cytokine storm associated with COVID, right? Like
Right.
that's a place where okay, our bodies are trying their best and they're confused, right? Like to personify our immune system, and we should probably dampen that, right? Because it's damaging, and there's probably other cases, but for the most part, my whole thought process is like this is healing, like you should let it happen.
Hey, super quick break from the podcast. Hopefully you're loving it. This is a way you can support the podcast and take advantage of a great offer. We're offering 50% off of one of our MCT bottles. MCT is an amazing oil. Add the ESS 60 molecule to it. It's even more amazing. All you got to do is leave a review on iTunes, send us a notification that you've left that review. We'll get you a coupon code that'll get you 50% off of our MCT oil and free shipping. Back to the podcast.
Does this impact your kind of position on cold plunges? Are everyone's doing cold plunges? Do you have kind of a position on that, and is it related to inflammation?
Well, so I'm not having my patients seek cold exposure immediately post-operative. And I'm saying in the acute phase of that first week. And a lot of that is just because that is another, cold plunging is a physical stress for us, right? So I am really metering the stresses that I'm dealing to them in that first week because they're already stressed and they're already healing. And we can measure this, objectively and qualitatively in their, heart rate variability, what's happening with their parasympathetic and sympathetic nervous systems in that recovery phase. So I'm really kind of, especially with my patients that are very in tune, which many of them are, we're watching that closely before we start introducing these other hormetic stressors, such as sauna and cold plunge and things like that. And so I would say the anecdotal interesting part of this is if I have a patient who is an avid cold plunger, I know without question that they are going to handle their postoperative recovery phase leaps and bounds better than somebody who is not accustomed to that. And I think that gets really into the anxiety and psychological part of it, of purposefully putting yourself in an uncomfortable position, knowing that there's a long-term benefit to it. And that's exactly what you're doing in a post-operative recovery phase, is putting yourself in that situation, knowing that there's a long-term benefit. So I like the psychologic part of ice bathing. This is what I use with my kids quite a bit. Yes, there's the physiologic benefits. Yes, it changes all that. But in the acute post-surgical phase, I'm not using it as much as I am leading through weeks 2, 3, and 4 afterwards.
So you are a self-described athlete and high performer. Do you do, because recently people have been talking about the cold plunges should actually be before you train, not after you train, like that can dampen it, or do you fall into that camp?
Yeah, I mean, I do both. And again, I'm a dad of 3 kids and have a busy life and, by choice, but I'm usually fitting it in when I can. If I have that like golden opportunity to like time out my day and work out and things like that, yeah, I like to do it before. But one of the things I learned, again, this is my oldest biohack, if you will, that goes back to training in youth, is I've been cold plunging since it wasn't called cold plunging. I was pouring ice in my bathtub so that I could train more when I was actively working out often, and I could get my 40 hours a week of training in, because it does up my, personally, everybody responds a little bit different, but it ups my training capacity when I'm ice bathing post workout. It does theoretically blunt your hypertrophic response if you're bodybuilding or trying to build those sort of greater muscles. But with those little micro injuries, let's say I was a triathlete, an endurance athlete, it really helped my recovery and my ability to get training volume in from a musculoskeletal standpoint, when I'm really looking at my cardiometabolic response to what my body could take. So I think there's benefits to both, and I still use it both ways. But again, a lot of it for me now is that cognitive benefit as much as it is the physiologic benefit. So I'm grateful when I get to get in there.
Yeah, when I interviewed a cold plunge expert, one of my questions was, do you think this is just the mental aspect, the fact that you're willing to dedicate yourself to this unpleasant experience, and that sets your course on a particular, like if you're doing it every morning, if you have that opportunity, that sets you on the course for a healthier day because you did something. We can even do air quotes, healthy for yourself that was, outside of your comfort zone. I think there's a lot to be said about that type of thing.
Absolutely.
When you were talking about hyperbaric chamber, the way you talked about kind of the puffiness and the oxygen kind of compressing on the inflammation, it sounded like you were reducing inflammation, but I don't think that's actually what's going on, right? Like that's just a description. You're trying to help the patient wrap their head around like what's some of the value here.
Yeah, it's reducing swelling more than it's reducing inflammation. And that swelling is just the byproduct of that inflammatory response. As you get increased blood flow, we get the extravasation of the plasma into the surrounding cellular tissue. Then it has to drain out from that extracellular area, which is what our lymphatics do. And post-surgically, there's lymphatic changes, and there's a big demand on our lymphatics to drain that out. In our head and neck, there's a very defined type of lymphatic drainage. But interestingly, going back to our filler conversation, most of my patients have had fillers prior. And so we know that they're having lymphatic drainage issues because that filler gets present inside of the lymphatics. It's sort of like having a slow drain in your shower. And, it drains, but it just takes a little bit longer for it to get out of there. And so when you put a big load of water, or in this case, a big load of edema inflammation in there, it just takes a little bit longer to drain. And you can pour Drano in there, which is like putting the dissolver on the enzyme, and it helps a little bit, but it doesn't usually fix it all the way. You got to call a plumber at some point to go manually remove whatever's clogging your drain. So it's not inflammation that we're blunting. We're actually optimizing the inflammation with the hyperbarics by getting a greater oxygen delivery. There's this diffusion curve that happens with how our blood cells release oxygen in these inflammatory acidic environments. So we have that we're optimizing by getting more oxygen delivery into those areas where it's usually difficult to get oxygen drop off a little bit or get enough oxygen to that healing tissue. So we're actually optimizing the inflammation and reducing the swelling at the same time.
That makes perfect sense. You mentioned autologous growth factors. I think in one interview I saw you're kind of pulling some very specific fats because of the stem cells that are located in those fats. Is that all kind of intertwined?
Yeah, it all kind of goes together. And a little bit of this is different purposes that I'm using it for. So when I'm thinking autologous growth factors or autologous stem cells, I'm usually harvesting those from fat because for me specifically, when I'm working with facial rejuvenation, there's volume loss in the fat pads usually. So when I take autologous fat, which I'm usually getting from around the belly button or the flanks or the thighs, something like that, I can take that fat, and most of the time people just re-inject it, but I take it through a centrifugation process using a centrifuge to spin it, and I can get the different densities of the types of fat that I want. So I can isolate the stem cell dense portion of the fat and kind of ditch the rest of the stuff. And in that stem cell dense portion, I have all the regenerative benefits that come with it. That's all the paracrine communication, all the Yamanaka factors, and all the interesting parts of what that does. But then I also have volume restoration into the fat pad. So I get this incredible double benefit with it. So physical, volumetric rejuvenation plus all the qualitative benefits of that. So that'd be one way that I use it. And then another one just comes in the family of like PRP, platelet-rich plasma. And that's, a lot of people have heard of that, but I use a little bit of a different version of that I create where I don't just take the plasma, I don't add an anticoagulant to it basically, but I do take your blood, I spin it down again with a centrifuge, and then I create this little gelatinous matrix that has fibrin in it. And fibrin is sort of that first step of our clotting response in our, another whole cascade of how we heal a broken blood vessel. But that fibrin acts is almost like a little spot weld type of glue, air quotes, if you will, that goes in there and is full of your own growth factor. So once I've finished working on an area surgically, I'll lay this gelatinous matrix of your own fibrin in there, and it quite literally helps to glue that area down and delivers all that growth factor healing, which reduces my potential space, reduces any bleeding, things like that could happen in that area. Again, very different. This isn't a normal thing that surgeons are doing. It's a little one of these innovative ideas that I've kind of run with, and it's being adopted now more, which is great. But it's 100% from you. So at the very worst case scenario, it does nothing. But we don't. That's not what I see. I see, quite a nice benefit to it as well. So that'd be like an intraoperative autologous from you growth factor or stem cell use.
And it makes a lot of sense, and yeah, it sounds like something that everyone would be or should be doing. I want to touch one more thing, and then we're gonna have to skip all sorts of questions that I have.
All right, no worries.
So all surgeries are painful, and I think some are significantly more painful. And now I know when my wife had a procedure done, one of her concerns was constipation caused by opioids.
Right.
What is different about your approach to pain?
Well, this has two factors to it. There's the what happens with the anesthesia, and then there's the what happens for the pain management before, during, and after surgery. And so opioids are a staple for both of those in general. They're a common part of anesthesia. I do not use general anesthesia for my procedures, and I think it's important to delineate that I'm working in a facial plastic realm. So, kind of from the collarbones up, right? So, I'm using IV sedation, that is a very progressive protocol that I've created that I don't use any opioids in at all. And as a side note, I'm not using any benzodiazepines either. So, I'm using that IV sedation from a consciousness control standpoint just to keep my patients at a consciousness level analogously just under the water instead of on the bottom of the ocean. I want to give them as little as possible to keep their consciousness controlled, but have them sort of asleep, but just gently asleep. Most of the actual pain control comes with really great local anesthesia. And that's a skill set in and of itself to be able to deliver that grade of anesthesia so that there's no stimulation to wake somebody up out of this barely asleep state. So that's the play between these two things. So the local anesthesia becomes the real pain control side of things. Well, we also know that post-operatively, there's big benefits to having good local anesthesia because there is never a signal sent to the brain telling it that something's in pain. It's generally with a general anesthesia, they're getting the pain signal, but the brain is shut down and it's just not receiving it at the time. But that signal is still being transmitted. And so once the general anesthesia is away, that there's a primed pathway of pain communication to the brain. Well, if we stop it at its root with local anesthesia, there's just never a signal sent to the brain that there's any pain in the first place. So post-operatively, there's not that primed pathway happening. This is the theory of how that works. After surgery, I'm then taking advantage of the ability of the face to achieve really good nerve blocks with local anesthesia. So I'm able to numb the face very simply with a local anesthetic that lasts about 72 hours. And for most postoperative pain, that gets us well through the period where there's generally postoperative pain. So I'm not using narcotics in the postoperative period as well. And that is successful well over 95% of the time with my patients. So if you are motivated not to take an opioid pain medication afterwards, you won't have to, basically. We can keep the pain control well within that threshold. So as you mentioned with your wife, there's better bowel function afterwards. There's better bladder function for people afterwards. There's a better neurocognitive benefit afterwards. And that is really my personal projection of my values onto this is I do not want to blunt a high-performing person's neurocognitive effect in the long term for an elective cosmetic procedure. I'm not willing to do that. So I am pouring into what I can do from an anesthesia standpoint to keep your brain functioning at, on all cylinders, if you will, without blunting it. Anyway.
One of your notes talked about anesthesia recovery and mentioned rectal ozone. Haven't really heard of that. Ozone, I've heard as being beneficial for other things, although I've never done the rabbit hole necessary to like what maybe I should be going in and trying this. How does that work? And then two, do you see ozone as beneficial in other areas?
Yeah, and this is really great. This is one of those fun things where there's an overlap of the biohacking and the medical side of things, but this one gets way more into, let's call it the biohacking, the integrative, the functional medicine side of things. So part of my recovery world that's been created is almost just like an offshoot is there's a whole functional or integrative medicine side of my practice that just blossomed out of the foundation that I created for the surgical recovery. So now I have these other practitioners, doctors, and PAs I work with who are incredible functional medicine and regenerative medicine providers, and I get to work with them, to help them. They help me optimize my protocols now, which is awesome. So in that functional medicine world, ozone is a big part of a lot of things that they do. But one of the benefits that it can have is for people who have, it's really rare to have, but if you have any post-operative nausea and vomiting, which is much more common, exponentially more common with a general anesthesia than with what I'm talking about, rectal ozone has been shown to help that. In my world, it's more somebody, once we have their genetic profiling and we know what their detoxification and their liver pathways look like, well, the medications that we're using in sedation are metabolized by the liver. And so if they're having any issues with that metabolic pathway, ozone can help that process metabolize faster and make that person feel better post anesthesia. Now, the rectal part of it is what sounds weird, but honestly, it's just the simplest way to get a gas into our body to make contact with the mucosa. And ozone is, instead of O2, what we're breathing in, it's O3. There's an extra oxygen molecule on there, which makes it relatively volatile, as we know from an oxidative standpoint. So it actually causes a little bit of an oxidative stress in our body, and that upregulates a lot of via some genetic pathways and via what's already existing. It upregulates our glutathione and superoxide dismutase and some other antioxidant pathways. So it's quite the definition of a hormetic stress. You give a little stress, you get a big response, and that helps us metabolize some of this local anesthetic. And so again, it sounds kind of funny, but for patients who need it, it can be a game changer for what they're doing, and it just branches off this other world that I have attached to me of functional, regenerative, and integrative medicine. It's pretty cool.
Yeah, talking about the fact that ozone it does actually oxidizes and is causes a hormetic response. Like, I mean, that's just the beauty or frustration, or we'll go with beauty of the human body, right? Like, to say that you don't want to be stressed is to say, well, let's not build muscle like that. Like, let's not do things that are actually ultimately good for us. And so you've got to have this juxtaposition. It's just, I think we're just keep honing in better and better on, well, what does that really look like? What is really kind of optimized stress? So I've got a couple of wrap-up questions, and we can do this rapid fire. The first one is, do you have a target age that you want to live to?
The real answer is no, I don't. But if I'm going to be forced, gun to my head to answer something, I'm going to say 123. And I'm going to
You
say
just want
120. We know the bio limit at this point has been verified at like 122. So it'd be nice to go 1 year beyond that.
yeah, because you are competitive.
Yeah, I am a little competitive. Yes, there's
If there were any doubts, we now know.
exactly.
Uh,
Exactly.
how long do you think humans can live?
Oh my gosh. Well, I mean, I think that there's a lot of answers to this as we understand environment, lifestyle, disease, and genetic aspects of this. I think that within the next few decades, we could easily be achieving what I'm talking about, which is like getting past that, current perceived limit, because we know that that's not actually the biologic limit. And if we can control some of these disease states, environmental states, that's very, very achievable. But I think if we think radically about it a little bit, we can get into what's going to happen with reprogram. Again, we talked briefly about Yamanaka factors and things like that, like reprogramming to make cells more pluripotent. We're quite literally epigenetically anti-aging cells, and the applications of that could be really big. And so I think if you and cryonics, and there's all kinds of things we could go into that could, instead of talking about adding years, be talking about adding decades, or down the road, even potentially, I think, centuries to what's happening here. But a lot of it is we're knocking on the door a little bit, and we just have to figure out what to do with these. You got parabiosis. We have all kinds of things that could be quite interesting to extending our longevity. And I think that, we're there. We just have to keep pushing, and there's ethical factors that go along with it, and there's all the limitations that that's going to pose to what science is doing. And I just kind of hope that that doesn't stop the progression a little bit.
Mhm. So I think it's kind of similar to my answer. Like, today's answer might be 123, right? Like, but tomorrow's answer could be very, very different.
Absolutely. Absolutely.
What are 2 to 3 protocols, habits, mindsets? Let's call them shortcuts, really, because everyone likes shortcuts to longevity and a long health span that you can share.
Oh man, I wish that I had like a really novel, blow your mind answer to this, but I think it's actually just, well, and I mean that kind of jokingly,
Rectal
because
ozone. That's all you need.
right, right. I wish it was that, but I think this gets into like as a doctor for my patients, as a human being who wants to be at peak performance for myself, but then as a father to my kids, the answer is going to be the same for all of those groups, basically. And it's sort of like, I'm going to say that sleep is your superpower. And it sounds so simple, but it's hard to optimize that. And I think that that's really important. It's something I personally work on. I talk to my kids about it all the time. And that's a foundation for a lot of things, from your cognitive function to how you're recovering from the things that you're doing. I think that stress management is a big part of that. And I think that there's a physiologic part, and I think that there's a big emotional part to what that looks like. We can't not have stress, as we've talked about 15 times on this show so far, but it's how are you managing that? And then what role is cortisol playing? And that's the real thing we're talking about. If we want to get to a baseline, is how are you managing cortisol? Because cortisol is helpful sometimes. We need it. It gets us up to do what we need to do, but we can't have high levels of it all the time. And so that's a simple thing we can test, and you can look at how your stress response is. And it's a great feedback loop that you can get to see how your stress management works and goes along. And then I think the other end of it is just the basics of like paying attention to your metabolism and what that is. And that involves exercise and what you're eating. And there is not a one size fits all approach to either of those. And that's like the fun part of it. If we want to look at it from a growth mindset side, is there isn't a shortcut there. You have to figure out from you what that is, what's sustainable. And you can do these cool genetic tests that can help you with some of those things as well. Like, you know, if we talk about the opposite of this, like what are people doing wrong? You know, I think it's
Wait,
thinking.
that's my next question.
Is it? Okay.
What are one to two things people are getting absolutely wrong regarding longevity and a long health span?
I love that. I think that is very simply telling me that I should only be eating meat, or I should only be eating vegetables, or whatever it is. And I tell this to my kids all the time too, is like, look inside of my mouth and look at my teeth. And it's hard to argue when I look at my teeth that I'm not built to grind things and I'm not built to cut things with them. And so from a start of my digestive tract, the very first thing in it, it's telling me what I should be putting in my body to some degree. Now there's variations within that. How are you doing with your essential fatty acids? How do you work with saturated fat? Do you have any specific sensitivities? Are you a celiac? There's all kinds of things that go into what you're doing with it. But from a baseline is, we should have some variation to our diet, and that just makes sense. And my mouth tells me that directly. So to get too typecasted into this one narrow thing, I think is a big mistake.
Yep. And then maybe another, so one to two things people get absolutely wrong.
Well, I'm going to say either one of the diets on either end, and then, kind of, I think getting into the other aspects of, I would say just kind of overthinking or overworking your stresses towards yourself. You have to be able to recover from them, and that comes with stress management, sleep, things like that.
Yeah. So in kind of the world of the conversation we just had, like maybe don't do cold plunges every single day, right? Like, maybe that's too much of a stressor. Manage those.
But that stress will change for you over time, right, Chris? If you want it to, when you do it, in my opinion, when you do a cold plunge, you want it to be hard. This gets maybe into a little bit of that. And if you do it every single day, at whatever temperature, it kind of is not hard anymore. And so you have to get colder and colder or whatever it is. And so again, I just think it depends on the benefit you're trying to get out of it. So I tend to go real cold for shorter amounts of time when I do it now. And I'm just via a life circumstance, I don't do it necessarily every day. It might be 5 or 6 days a week, but when I get in, I want it to be a challenge for myself.
Dr. Chesnut, how can people contact you?
Best way to, I think, just kind of get a hold of me or check out what I am is to go just to my Instagram page. That's where the most effort goes. And you can just check out the 3 posts that are pinned up at the top and get a good sense of who I am and what's there. That's my practice is built off before and after photos. That's people travel from all over the world to see me. And that's really why my practice is very travel based. It's very concierge. You come in, you see me, you have this whole experience of all the things we've talked about today. And so in preparation for that, I think that's a really good way to get to know me. There's a lot of educational content on there about pre, post, during, how to manage different situations, and then a lot of before and after photos. That's the simplest way.
And what's the handle for IG?
It's my last name is Chesnut, Chesnut, MD, at Chesnut MD.
Chesnut MD. Excellent. And what in the near future are you excited about?
Oh, man. Well, the spot I'm at in my practice, I'm more than a decade into practice now, and I have this wonderful handle on all these progressive procedures that I'm doing, and I'm in a great phase where I'm teaching. I have 2 fellows every year who are with me, and they're learning, they're immersed in that year. It's the most intense, fun year of their life, in my opinion, from a training standpoint, at least. And I get to just chat with them all the time. They're so much smarter than I am, pick their brains, get into all these worlds. And so my phase of life that I'm in right now is really progressing and creating these new avenues to procedures. For example, cutting out a buccal fat pad, which is a really common procedure that people do, tends to hollow out the lower face over time. It looks good initially, looks bad in the long run. And so we've innovated a way to, instead of cutting that fat pad out, to lift it up. And I might be the only surgeon in the world who does that right now. And so just kind of creating these types of procedures that kind of make sense, if you will, but having the surgical capacity, the room, and the foundational knowledge to kind of make these little changes. It's just something that fuels me. It's definitely one of my missions. And I'm in a great spot to be doing that coming up. And it just gives my patients better results and makes me more satisfied.
Yeah, that's really cool. You know, they say that you really have to like know how to do things right before you can then make improvements on them until you can actually start contributing to that particular science.
Absolutely.
All right. So you can find Dr. Chesnut on Instagram, Chesnut MD. That's CHESNUT MD. Your clinic's website is clinic5c.com, right? Is that correct?
Another great place. Yep.
Excellent. So go check those out. That was where I pulled some of the quotes of the Monaco Plastic Surgery Group or whatever that group was. That's also impressive. So yeah, you can find him at those two spots. Dr. Chesnut, thank you so much for joining us today.
Yeah, I appreciate your time.
I hope you enjoyed this episode of the Live Beyond the Norms podcast. Make sure to subscribe and follow. Also, make sure not to be that guy, the guy sharing this podcast with people who are not interested in living beyond the norms. If you would like to learn more about the ESS60 molecule, the molecule responsible for the single longest longevity experimental result on mammals in history, a full 90% extension of life, visit myvitalc.com. That's myvitalc as in carbon.com.